I'm Dr. Prabhu, Pediatric Urologist in Hyderabad. Today we are going to discuss about a Pediatric ECIRS, which is Endoscopic Combined Intrarenal Surgery for a complex renal calculi, that means renal stone. Here is a 1-year-old child. There's a clinical picture of 1-year-old child with right 10 mm left 10 mm pelvic calculi and a 5 mm lower polar calculi. You can see both the calculi in this plane of in the axial section of this CT. The child is pre-stented, and as well the important thing I wanted to highlight here is the IP angle, which is infundibulopelvic angle. Generally, when the infundibulopelvic angle is more than 120, it's really complex to get this flexible scopes into the lower pole calyx or into the calyx deside. So that is why the combined intrarenal surgery is taking place in this child. Let us get into the details of the procedure. Now, the guide wire is already placed. Once the stent is removed, and you are seeing the 9 French ureteric axis sheath getting into the left renal system. And once you can see the ureteric axis sheath is driven inside with rotatory movements gently. And one important thing I want to highlight here is you have to stop short of the PU junction, so that you are not injuring or there is no ischemic injury to that of the PUJ. Now you see here is the axis sheath. You could see the axis sheath here and the 2 calculi here just below the PUJ. And this is how the axis sheath is placed, and here is 7.5 French ureteric flexible ureteroscope, and your assistant should be helping you to guide the ureteric axis sheath into the system. So once the ureteric axis sheath is into the system, all you need to do is get a laser and with an appropriate setting. Once you push the stone into the calyceal system, you can either decide to fragment or dust the stone. So when you want to fragment it, you have to use a high energy and low frequency, and when you want to dust it, you have to use a low energy and high frequency. And finally, this is the appearance of the stone at the end of the fragmentation or dusting that is taking place here. And you can also have a look at what settings we have used as mentioned, and that depends on child to child basis depending on the size of the child. Here you see this is the infundibulopelvic angle. Here we are able to negotiate the scope, but once we are getting the guide wire inside or the laser inside, we are not able to get into the calyx. So now what we did, we used a spinal needle, 20 gauge spinal needle, and the stone guided puncture is being done. You can see the needle getting right into the system with the stone, and once the needle was in, then the track was dilated up to with the 16 till the level of 16 French ampler sheath, and you can see the ampler sheath is around 16 French. Now 12 French nephroscope is passed, and you see the tri-prong in action taking out the stone. So this is a combined procedure. All I wanted to highlight that is this is a combined procedure. You see the ureteric axis sheath and ampler sheath here, and you see the stent and malicot down at the end of the procedure. Here is how the malicot is being placed as a PCN. So in short, if I have to tell you what has happened in this is an animation depicting the same. Here was the pelvic calculi which is being pushed into the calyces, and then it is being dusted, fragmented, and then finally dusted. And after that, we couldn't, once we tried to negotiate the same scope, the flexible scope, into the lower pole calyx because of the IP angle, we couldn't manage to do so. So what we have done, we have made an ultrasound guided puncture, then after that we put an axis sheath, ampler sheath, and finally the stone has been retrieved with a puncture. This is a very complex procedure, needs lots of technical expertise to complete this procedure, particularly in a child which is 1 year. And this is what I wanted to, this is the beauty of pediatric urology. And in short, I want to give a comprehensive look. So here is when the angle is, when the infundibulopelvic angle is quite high, you are not able to negotiate. You are able to negotiate your flexible ureteroscope, but when you put in a guide wire, it becomes much more. When you put in a laser, it becomes much more rigid, and it's not possible for us to negotiate it inside. So we did a puncture and a lower calyceal puncture, stone guided, and finally this is how we play. This is the final picture of the entire procedure. And In conclusion, the ECIRS got its own advantage when you have a very complex anatomy of the stone in a given situation, and which is because of the two combined procedures, we have a significant stone-free rate in the children, and also very less radiation, and we have very less punctures, less bleeding. You have the entire anatomy analyzed even before you proceed, because you're already visualizing the calicine system with the RIRS scope, and then you're taking the puncture. So all this is because of visual supervision that happens. So thank you for listening.